And good afternoon, I'm Dr. Deuk. Our patient has 2 herniated degenerated discs in her neck. We've already performed the DPR for facets, and now we're going to do a Deuk laser disc repair. All right, Jordan, I think we're off on WAG, or sorry, orbit. You can see the double facet. This patient is going to have number 5, 6, and 6, 7 fixed. We start at the top with number 2, 3, 4, 5, 6, 7. All right. Let's take a look there. That's better, almost perfect. Let's just do a tiny bit more. Tiny bit. That's fine. Okay, first thing we're going to do is access the spine through the front. And to do that, I'm going to touch her spine with my fingers. She's completely asleep, intubated, and chemically paralyzed with a muscle relaxer. Shot. 2, 3, 4, 5, 6, 7. Luis, you have 6, 7? All right, let's get an AP. So we want to use the lateral view as well as the front back view to make sure we're in the middle and we're right over the disc that we want. Okay, I'm a little bit to her left, so I'm going to push a little harder. Shot. There we go. Lateral. I'm actually resting my fingers on her spine right now as we speak. 2, 3, 4, 5, 6, 7. All right, I'm going to move slightly north with my needle and then pull everything south. Shot. Looking good. And I'll go down to the spine. Shot. AP. Quick AP. I want to see that I'm in the middle of the spine. Quick AP. And I am. So lateral. Come on, Jordan. Yes. Very good. I'm going to enter the disc. Shot. There we go. All right, I'm going to advance the needle slightly so that I can get into the center of the disc, and I'm going to do a discogram. The discogram will show me the tear and the herniation. Shot. Oh yeah, shot. There it is. Look at the tear. Huge. This patient has a massive tear in the back of her disc. It let all the dye out. The dye should not go to the back of the disc. Normally, the only way it can is if there's a tear. Shot. And there clearly is a tear. You see how quickly the dye dissipates? Shot. All right, at this point I'm going to shot. Yep, I'm putting a guide wire. We're going to make an incision. The incision for the surgery, since it's a full endoscopic surgery, as minimally invasive as it can be, is 4 millimeters. We're doing a 4 millimeter incision. Let's see. Yep, perfect. You guys see that incision there, Henry?
Yes, we do.
All right, now we've made our 4 millimeter incision. The whole surgery will be done through this tiny 4 millimeter incision. It'll look like a vampire with a tooth extraction did her surgery. This is the surgery other spine surgeons wish they could do, but they haven't been trained to do it yet. Shot. Let's get another one.
Another dilator, please. Yep. Yep.
Will you take that and put it on the table? Luis needs to have a look at that. So at this point we have placed the guide wire, which will guide my dilator. Is that right now? Okay. You guys see the dilator here?
Yes, we do.
I need you to verify it. And then we need to take some action. I want to know who is responsible. All right. No, you're good. Just relax, Sean. So I can actually feel the disc. Let's do an AP view. At this point, I've advanced this little dilator through the incision, and the tip of the dilator is at the front of the disc. We have to now pass through the disc to the back. Perfect. You guys see the middle right there? Show us the middle, Jordan. That's the spinous process. It's in the middle. So the tip is right in the middle. Now you don't have to be exactly in the middle when you go into the disc, but you should be within a centimeter of the middle, left or right. Now I prefer to go as perfectly middle as possible. That's just my nature. I always want to do as good as humanly possible. So you're in the middle. You're now going through the front of the disc. I'm going to advance this dilator right to the back where the tear is. You see how it's at the tear now? You all see that?
Yes, we do.
All right, now I'm sitting at the back of the disc where the tear is, and I'm going to now, just so you can see the steps here, you see that's the tube. I'm doing the entire surgery through this skinny little tube. That goes over the dilator, and the outer diameter of this tube is 4 millimeters, so you can see it fits perfectly through the incision. And now I'm at the front of the disc. I can feel it. Shot. I'm going to advance the tube. Shot. We're going to take lots of pictures because I want to make sure it's done safely. Distraction. Now you see the dilator came back a little bit. Now it went forward, so we got to keep an eye on that dilator because it can do some funny things. Back, front, and we want it to kind of stay where we put it, but it does wiggle around sometimes with the impact. I just want to get it right there. Should be good. I'm going to advance once again the tube over the dilator. Shot. And what's pushing the dilator back is inflammation inside the back of this disc. We see this from time to time. Remember, the pain she's having comes from the inflammation. So it's no surprise that there's inflammation here, and the inflammation causes swelling. Perfect. That should be good. All right, now the tube, one more shot, is docked at the back of the disc. Show us that there, Jordan. The tube is literally inside the annular tear, and it's looking directly at the herniation, which is right on top of the spinal cord and the nerves. So we're working, and we're going to remove herniation from on top of the spinal cord and nerves. She comes from Virginia, correct?
Yes.
Yeah, she's from Virginia. She's had neck pain for years. And you guys see her neck right here? We've literally lost probably 2 drops of blood. That's all. Let's go. Thank you, Luis. Any questions from the audience?
Yes, we have a question from Rita on YouTube.
All right, before we get to Rita's question, let's show our audience why herniated discs cause so much pain. And then we'll get to Rita's question. Welcome back. You can see from that video, why do people get so much pain from a herniated disc? The answer is always inflammation. And what causes the inflammation is that the herniation gets stuck within the annular tear. And once it's in there, it irritates the inflammatory system. It sends signals to the inflammatory system. Hey, I'm over here, I'm doing bad things. The inflammatory system's response is to attack it. And that's what the inflammatory system does. It literally attacks the herniation. And it's the attacking of the herniation that causes all the pain and discomfort that the patient has. It's the inflammation. It's basically a war between your inflammatory system and the herniation, with your inflammatory system trying to get rid of the herniation. All right. Looking good. A lot of scar tissue, what I'm seeing here. Lots and lots of scar tissue. These are bone spurs as well. They're not supposed to be here. She doesn't need all of them taken out, but I have to remove some of them. Any questions?
Yes, we have a question from Rita on YouTube.
Hi, Rita, welcome.
And they ask if I can only get updated on my back and hip x-rays at this time, would that help? For some reason, my last MRI long ago only showed knees, but the x-rays recently show that I'm in severe pain.
I'm not really sure what you're asking, Rita.
Yeah.
I apologize. I'm unclear what it is you're asking me. Are you asking me what was the question once again?
I'm trying to word this correctly. It's a little confusing. If I can only get updated back and hip X-ray at this time, would that help? For some reason.
I see.
Yeah.
Yeah, we don't. The X-rays of your back are helpful, but they're not going to be enough for an MRI review. We must have an MRI to do an MRI review. So I don't know if that's not an option, but how old is your MRI of your back? If your MRI of your back is within 18 months, it should be fine to use it. And then the X-ray can help a little bit, but we do need the MRI of your back. And for your knee, I think if you've got an MRI of your knee within the last 2 years, it should be okay. An X-ray would be helpful. Submit it, and worst case scenario, if we're not able to use it and we need more, we'll tell you. Okay? So far, everything's going well. This is the herniation. The laser is removing it little pieces at a time. The herniation is stuck down to, that's a bone spur right there, by the way, right there. Okay, you see that bone spur? Now I'm going to literally vaporize the bone spur. It's going to go bye-bye. Because that bone spur happens to be right above the nerve. And from my standpoint, I don't like that. I think there's a chance it could be causing symptoms. You see that? Like a little dagger. So,
Yes, we
people
do.
asked me if we can remove bone spur. We just did. That was the bone spur. Now, there are other bone spurs I'm not going to remove. My goal here is not to remove all the bone spurs. My goal is to treat her symptoms and get rid of what's causing her symptoms, which is mostly this stuff here, herniated disc. When I say herniated disc, I'm also talking about the scar tissue that is there with the herniation that scars the herniation into place. So it makes it hard to remove it. Yeah, that's why you need the laser. There's no way to remove these pieces of herniation, like right here, you see it? That's huge. It's a big herniation. We call it a reverse herniation because it's coming back to us from where it was pushing on the nerve. There's another one. So those are all herniations that she's had for years, You can tell from how much scar there is and calcium there is. And we just got rid of them. Just lasered it to release it because it's stuck and it won't come up otherwise. And the laser also breaks it into smaller pieces, so it's easier to float up and out. Anything coming up towards us in the tube is coming out. So there it goes. Now this is, look at all the gold color. That's calcium. That should not be there. This is abnormal. Abnormal means not normal. And everything abnormal has the potential for causing problems for the patient. But not everything abnormal causes problems. So that's where the experience of your surgeon and team come in. You know, we want to make sure that we're focusing our treatment on the things that need to be treated that are abnormal, not just anything abnormal. If we're doing anything abnormal, we'd be taking the whole disc out, because there's nothing normal about her disc. You understand? The whole disc is abnormal, but it's not causing symptoms. The key in healthcare and treating patients is to treat the abnormal that causes the symptoms for the patient, so that their symptoms go away and they're able to function normally. And that's what we do. We're treating the abnormal that is a problem for the patient, not just any abnormal. Just about done. I got about 3 minutes left on this disc, and then we're going to go to the next disc. The next disc is one up. It's number 5-6. There's all herniation here, by the way. All of it is totally abnormal, and it's sitting right on her spinal cord and the nerves, which is why it needs to be removed, because it is causing symptoms. Look how nicely we can see everything here, right? You guys see it?
Yes, we do.
So the endoscope makes it much easier for a surgeon to see what's really happening in the back of the disc, right where the herniation is. Without the endoscope, I wouldn't be able to see. This is all scar tissue, and it should not be here. It's all abnormal scar tissue. It's here for one reason: inflammation. So the herniation caused inflammation. The inflammation caused scar tissue. The scar tissue is putting the pressure on the nerves and the spinal cord. And I'm removing the scar tissue and the herniation, both. All right, just about done. She's had a lot of numbness in her hand. The numbness comes from either pressure or inflammation on the nerves, either in the nerve root or the spinal cord. Both can do it. So we're treating both. This is the foramen. We got one more disc, Dr. B. Okay. Dr. Burndes? Yeah. We're going to do the other disc next. There's a big piece of herniation right there. See that? Luis, I'm going to try to grab it. I don't know if I can grab it. So some pieces of herniation are pretty large, like this one, and if I can't grab it and pull it out, oh, we did. Then what I do is I use a laser to cut it in half, and then it becomes easier to pull out. In the end, everything has to come up this tube in order to get it out. That makes sense? If it don't come up the tube, it's not coming out. So the whole surgery is done through a tiny little tube. It's an endoscopic tube. It's 4 millimeters wide. And that's really the reason why we're able to do the surgery endoscopically, is because of the tiny tube we use. Without the tube, we wouldn't be able to do the surgery. This is her foramen. I'm seeing a lot of bone spur, but even more scar tissue from inflammation that's been going on for many years. I'm going to take one more look on the other side, and then we'll be done with this disc, okay? These are the bone spurs, by the way. These are not pushing on the nerve, but I needed to get through them anyway because they were right over the nerve, and there was some herniation underneath them. This is the other side. There's a little bit of herniation left here, and then we're done. And I am literally peeling 1/20th of a millimeter at a time. Thanks. We're going to be done soon. All right, that's it. That's some scar tissue. Remember, you can't get rid of all the scar tissue. Just not possible. Not humanly possible. We're not here for the scar tissue. We're here for the herniation. Now, some of the scar tissue we do want to get rid of because it's pushing on the nerves and spinal cord, causing what we call mass effect. Mass effect. And mass effect, when it comes to neural structures, is never good. You guys see that right there? That's pretty cool, that little window that just opened up right there. That's the spinal cord and the nerve. And this stuff is just sitting right on the nerve. And there's no other surgery in the world that lets you do what I just did, except the Deuk laser disc repair. All right.
Please, thank you.
Again, this is the future. If you guys could fast forward time, 50 years, 100 years, this surgery is what every spine surgeon will be doing. We've just discovered it first, and we're doing it first. But unfortunately, getting these other doctors to change their behavior and patients to be aware of a better surgery is so hard to do. It's really hard to spread information. I never realized how hard it was to spread information. You'd think that new discoveries would be embraced by everyone and promulgated, but that's not the case because unfortunately the way our world works, there's a lot of powerful, wealthy corporations and people that are greedy that all they care about is the money, and because they're going to stop making a lot of money when this surgery is adopted by everyone and used by everyone, all the surgeons, all the patients, because there's some very powerful corporations like insurance companies, implant companies, they're all going to lose billions and billions of dollars. Because of that, they don't want this technology out there. So they are literally putting the brakes on it. And it's not just them, it's also neurosurgeons, unfortunately. 2, 3, 4, 5, 6, 7. We're going to go up one level. I'm going to take the tube out. So, shot. In the end, my loyalty is to my patients, nobody else. I serve my patients. I do what's best for them. Not my employees, not my partners, not me, my patients. And because of that commitment to doing what's best for the patient, that puts me at odds with virtually every other neurosurgeon and spine surgeon in the country, because they're not really interested in doing they want to do what's best for themselves. AP? But I truly believe doctors are supposed to do what's best for the patient. And, go ahead, lateral. My father taught me that if you do what's best for the patient, you'll be busy. You'll be a good doctor. You'll be successful. and I still believe what he said is true. So, from my standpoint, doing what's right for the patient is doing what's right for everybody else too. All right, we're moving north. Shot. All right, I'm off to the side. I need to figure out which side I'm on. Quick, just bring it up. Yeah, I'm off to the right. I'm going to move it to the left. Shot. Not far to the right, but shot. All right, not bad. Let's go back to a lateral. Uh-huh. So I'm making my way up to the next disc. We're almost there. Shot. Shot. AP. At this point, I'm over the next disc, on top of it, but I need to be in the middle. So I need to check. Quick shot. All right, I'm a little bit off to her right. I want to correct that. So I want to come back to her left just a little bit. Hopefully that did it. Shot. That's perfect. Let's go lateral. All right, so we are now at 5-6, which is the next disc. Yes, perfect. And I'm going to enter the front. Dr. Berndes is going to give me a little inline traction to make it a little easier. Shot. I'm going to do my discogram so we can see the tear. Shot. It's nice and clear. I'm giving you all the play-by-play. Inject. Shot. There's the tear. You guys see it? Shot. All right. So there's the tear, and then the dye leaked past and started going everywhere else. Shot. I got to get to the back where the tear ends. Shot. That's good. It should be right around there. We're going to go in, put our tube. This will be the last disc we're doing in this patient. The next patient we're doing is in room 3, right? Or 2? Where's the next one? I thought it was a DPR. Oh, the DLDR is first?
Yeah, because they have ID access now.
Oh, okay. Never mind. So I guess we're doing a DLDR next, and then we'll do the DPR. But the DPR will be in room 2, so you guys won't see it.
We have a lot of questions, actually.
Fine.
This next one comes
Are
from...
you pulling?
This next one comes from Rita, once more on YouTube,
Hi, Rita. Thanks, Luis. That helped.
asking, steroid injections gave me shingles since I am immunocompromised. Can you use anything else? You said you use steroids after for inflammation. I'm trying so hard. I'm in Canada, but nobody will say it's okay for me to try. But I really want to try.
Yeah. So to answer your question, you don't need any steroids with our procedures. If you don't want steroids, you just say, I don't want steroids. We do the procedure without it, and it works well. Okay? And yes, steroids do cause shingle to occur in many patients, not always, but clearly it happened in your case.
This next question comes from Cosmic Knight on YouTube.
Welcome back, Cosmic Knight.
They asked, I have neuropathy. When asked to place both hands together and press palms together, I had to stop because of the extreme pain in my left wrist. Is this related to vertebral issues or carpal tunnel?
I don't know. That's a great question. Cosmic Knight, it could be related to arthritis in your wrists. I've never heard of that with carpal tunnel, and I don't think it's a vertebral issue. I think it's a joint issue, but we can fix it, whatever it is. So my advice is come see us and let's get you fixed. Whether it's a joint issue, whether it's a carpal tunnel, it doesn't matter. We treat all those things. All right, this is a more complicated disc. Tremendous scar tissue. Tremendous bone formation, osteophytes, bone spurs. You can see them right there. Golden color. Look at that thing. All scar tissue, massive. So this is where the herniation is. And it's a herniation that's so old It's been wrapped up in scar tissue and mostly replaced by scar tissue. And that's what we're seeing here. There's a herniation. See that? Wiggling its little head.
Yes, we do.
Saying, who is here? Why are you here? What are you doing here? We're here to get rid of you, herniation. You're public enemy number one. All right, other questions?
This next question comes from Tracy on Facebook.
5 minutes. Tracy, how are you? Welcome.
They ask, curious, how often after a lumbar DLDR where you treat one side, do you later end up treating the opposite side at the same level?
It's very rare. Tracy? Tracy?
Tracy, correct.
Yeah, very rare. Less than 5% of the time. Now, I will tell you this, if you come to me and you've got leg symptoms on both sides, whether it's numbness, tingling, or weakness, I would recommend fixing both sides. But if you have symptoms only on one side, it's very rare that we would do the other side in the future. It's not common. Probably 5%. I don't know the number, but I would guess 5%. Just about done. A lot of bone spurs, but they don't need to be taken out. Just these herniations do. Keep going, Henry.
Next question comes from Liliana on Facebook.
Hello, Liliana.
They said, hi, Dr. Deuk and team. My question is, I've heard Dr. Deuk state in previous videos herniation parts would be sent to the lab.
Yeah,
Curious
correct.
to know the lab results, if you could share.
Sure. Yeah, what we're looking for is primarily, are we dealing with a herniation? Or are we dealing with a tumor? So the standard is to just send the pieces to the lab to make sure there's no tumor. So the results are always the same, and they say degenerated fibrocartilaginous material. And that's what we're looking, okay? We just want to make sure it doesn't say cancer. That's why we send it to the lab. That's the main reason. To verify we're dealing with a herniated disc.
Blue towels, please.
What's going on there, buddy?
Blue towels or white towel, maybe? You gotta need a white towel.
We got 2 minutes left. Berndes? 2 minutes.
Is it overflowing or is it just?
Oh, there's a lot of irrigation. Henry, you just keep bombing me with questions.
No problem. Next question comes from Simo134 on YouTube, asking, how effective are anti-inflammatory supplements to combat the inflammation of the disc bulge?
Totally ineffective. Yeah. Taking oral anti-inflammatories to combat the inflammation from the disc bulge is very ineffective. It's like throwing a few drops of water on a fire. You know, is it not effective at all? Pretty much. Will it make you feel better for a little while? Sure. How long? Maybe a few hours. But while you're taking those anti-inflammatories, you're destroying your kidneys. Remember that. Every anti-inflammatory pill you take goes to your kidneys, and it ruins your kidneys. It also eats the lining of your stomach and causes an ulcer. So, you want to avoid anti-inflammatories for things that are fixable with this procedure. Save your anti-inflammatories for things that aren't fixable. Anti-inflammatories are very dangerous medicines. A lot of people don't realize that. In most patients, you're okay, but in many patients, they cause renal failure, kidney failure. And they do it because they create what's called interstitial nephritis. They destroy the inner workings of the kidney. And when your kidneys fail, guess what? You're going on dialysis. And if you think life is miserable now, go on dialysis or talk to somebody who is on dialysis. That's my advice. Don't abuse your body with drugs that are unnecessary and dangerous. Whether they're opiates, whether they're anti-inflammatories, doesn't matter. It's all bad stuff. Huh?
2 minutes?
Yeah, 2 minutes.
Next question comes from Rita, once more on YouTube,
Uh-huh.
asking, I know someone with lytic lesions on the bones. Can you help that?
Nope, I cannot help that. That is cancer. Lytic lesions in the bone is usually cancer. That's not something we treat at Deuk Spine. We treat degenerative conditions, not lytic lesions, not cancer. Sorry. They need to see an oncologist. An oncologist is a cancer doctor. I would recommend they see that person right away. This should be it right here. Yeah, we don't do cancer treatments here at Deuk Spine. Thank God cancer's rare, but it's not zero. Someday, hopefully, they'll come up with a cure.
And so far, no current questions.
Wonderful. We are pretty much done. I'm just getting this last little bit. And that should be it. Oh, one piece here. Flip it. This should be it right here. This is the last of the herniations. And it's a big one. Oh, he snuck behind me, huh? Let's see if I can't get this thing out. Boy. Yeah, that was a good sized one. Well, Berndes, once I get this, we'll be done. Any other questions?
At this moment, no current questions.
All right. So the next patient we're doing is going to be a lumbar Deuk laser disc repair. 3 levels. She is from
The island of Bermuda.
Bermuda. Now, lots of people get lost in Bermuda, but she found her way to Deuk Spine. Remember the old Bermuda Triangle stuff when we were kids? Huh?
Yeah. The boating and the planes.
Yeah. Everyone was so scared of the Bermuda Triangle. That was a thing.
Sitting down, please. Thank you.
All done. All done. All right. If there's questions, type them up. I'll answer them face to face while the room is turned over and we get ready for the next patient. Type them up for me, and I'll come answer them. Once again, we've lost virtually no blood. We'll call it 1 mil, 1 cc.
We're going to need a medium CPAP mask for the next piece.
All right, I'll show you guys the incision here. On her neck. Can you see okay, Henry?
Yes, we can.
right there.
Perfect.
4.5 millimeters. 4.5 millimeters. So, what are you gonna do? Ioban and benzoin. Let me have it. I'll do it for you. I'll put it on. Let me have the steri strip. I'll cut it if it's not already cut. Let me have it. Oh, where's the other one? Oh yeah, this is good. No, it's good. Let me have a scissor. Put it. So we're putting a little bit of benzoin, which we use to prep the skin for the steri strip, which is the Band-Aid, the bandage, basically. All right, all done? Thank you. Good job, everybody. Let's go to one of our patients, Henry, that had this done.
Copy that.
Good morning, I'm Dr. Deuk. I'm here with one of my patients from Canada who traveled actually from Toronto to Florida to have Deuk laser disc repair to fix 2 herniated discs, one in his neck, one in his lower back. And you had your lower back done last week, and we were actually supposed to do your cervical last week, and we had our air conditioning break, and we got it fixed over the weekend, and you had your neck done yesterday. So you've actually had the Deuk laser disc repair done on your neck and your lower back. How's your lower back feeling?
Brand new.
Amazing,
As if it was never injured. I still am in shock. I can't believe that you were able to achieve this result after I've been suffering with this problem for just over 5 years now.
Yeah, since your accident.
Yeah.
Trauma is the cause of herniated discs. You herniated your disc in your lower back. You had pain for 5 years. In Canada, what did they do to treat your pain in your back and your neck?
I started with medications, nerve meds, narcotic painkillers. I was instructed and told to have nerve block injections to help with pain management. I did physio, I did chiro. Finally, I got to a point where I started to do the nerve ablation therapy, and I did 2 rounds of that.
But the pain came back.
And the pain always came back, and I was looking for a repair, a permanent solution, so I can get back to, having some normality of my life. And I found the Deuk Spine Institute, sent my MRI over right away. I had my consultation within not even 10 days with Dr. Deuk in person, like in Zoom. 3 weeks later, I flew out here and I feel like brand new.
It's amazing,
so thank
isn't it?
you. Yeah,
You're welcome. You're welcome.
This was life-saving for me because I didn't really have a great life before this experience.
And you can tell the pain is gone now.
Yeah, I was having numbing in my legs. There was days where I couldn't even walk. I was completely debilitated, stuck in the house, pain, numb. I thought I was going to be like paralyzed at one point. That's how bad it was.
And how are those symptoms now that you had the procedure?
Gone. I have full feeling back everywhere. Like, it's unbelievable. I can't believe it.
All with the Deuk laser disc repair. You could see we went in and we found the actual tear where the herniation came out in the back of the disc, and we used the laser to clean it out, debride it. Now here you are doing fantastic.
Yeah, thank you.
You're welcome.
So much.
Is there anything else you want to tell your fans out there?
I did my neck. I did my lower back. I had the worst symptoms. I came here, an hour each procedure. This is the day after. I had my procedure yesterday at, what time did you take me in? Like after 9 maybe?
Yeah, around 24 hours ago.
And I haven't taken any medication since I was discharged and gone back to the hotel. Not even Tylenol. Like, I feel great. It's unbelievable. I highly recommend anyone that's suffering like this to just come out and get fixed, because you will definitely have a way better quality of life. don't suffer.
Yeah, don't suffer.
Don't suffer.
We can fix the back and neck
There's
pain
a
here.
solution. He's the solution.
Thank you.
This is real. Everything you see on the internet about Dr. Deuk is real. Any negative reviews you read about Dr. Deuk are none. They're not real. They're just people that are just not happy with themselves, because I read them all on Google and I had to make this decision, and I'm very glad I did, because I believed everyone that was talking about their results, and here I am. So thank you.
Congratulations, my friend.
Thank you.
Enjoy the rest of your life.
Thank you.
Yeah, you're welcome. All right, let's get you out of here. Wow, what an incredible testimonial from one of our patients who had the Deuk laser disc repair for some disc problems. And well, we just finished this patient who came from Virginia, and she had two problems. She had facet pain in the back of her neck. When she turned to the side of the facets that hurt, it hurt her more. We just treated the facets. They're full of arthritis. And then we also treated two discs that both needed to be treated. You see the herniations. She had pain coming from them based on her exam. She had numbness and tingling in her hands. So hopefully that will all be gone at this point. But I was very pleased with the results. The surgery went smooth. We lost literally maybe 10 drops of blood, and the patient was asleep. She's going to take 2 hours, recover, and then go home. And home really is the hotel, because 80% of our patients now come from other states, other countries, so their home is far away, and we do want to see our patients the next morning and check on them. So she will stay in the hotel tonight with her husband, and then we'll see her tomorrow, and then she can go home to Virginia. But basically the recovery is quick. It's just a couple of hours, and then you could literally go back to work if you wanted to the next day, obviously with restrictions, so you're not lifting anything too heavy. All right, Henry, we have some questions.
Yes, we do. This first one comes from Simo134 on YouTube,
Hello, Simo134.
asking Dr. Deuk, do you know about PRP epidural injections into cervical disc areas?
Oh my God, PRP epidural injections. I would not do that, but you know, I'm a bit of an open-minded person to new technology, but PRP injected around the spinal cord, I don't think it's a good idea. PRP is pro-inflammatory. It creates inflammation. A lot of people don't know that. That's how it works. And so if you're injecting something that causes inflammation around the spinal cord, you're asking for big trouble. You could cause a hemorrhage, hematoma. You can cause transverse myelitis. There was a drug they used to use, chymopapine, a long time ago, that caused those kind of problems, and people were becoming paralyzed from the injection. My advice is stay away from it.
Next question comes from Izod on YouTube.
Hello, Izod Lacoste.
They asked, hi doc, what if, excuse me, what if herniation develops again? Will the procedure be repeated, or disc replacement remains the only option?
Yes, we've had reherniations in our patients. Our patients reherniate 1%, so 1 in 100 will reherniate. We just did a reherniation a couple of weeks ago. The patient had the laser surgery. He was doing fantastic. He went out fishing at 7 weeks post-op and caught a big fish, a 100-pound fish, and pulled it in, and re-injured his neck, re-herniated at the same place I fixed him. Now I fixed 2 discs on him. He only re-herniated at 1. So we went back and we did the second surgery, laser, at the same place, and it worked perfect. No, you don't need a disc replacement. You don't need a fusion. You just need to repeat the Deuk laser disc repair.
Next question comes from Rita, once more, on YouTube, asking, can you be on Valium and Tramadol while having your back surgery?
So Rita's question is, can you be on Valium and Tramadol while you're having your back surgery? We prefer that you're not on Tramadol, an anti-inflammatory, though it is also kind of I think it's a lower dose narcotic, but it wouldn't be the end of the world. Let's put it that way. You could probably get away with it. The Valium I'm not excited about, but if we had to, yes. The problem is those drugs can interfere with the drugs we're giving you for anesthesia. It could accentuate the effects of anesthesia and make you more drowsy. So could we do it? Yes. but we just need you to be very honest about how much you're taking with the anesthesiologist so we can calculate, with the other medicines we're going to give you, how much we should give you.
Next question comes from Simo134 once more on YouTube.
Hello, Simo, once
Yes.
again.
Asking, can you tell from MRI images how much calcification the disc bulge has?
So Simo says, can you tell from an MRI image how much calcification the disc bulge has? The answer is no, we cannot. It's impossible. Give me 1 second. I've got a call from another doctor. Okay. Sorry. Yeah. So the standard MRI scanning sequences do not detect the amount of calcium in the disc or behind the disc. What would potentially help is a CAT scan, CT scan. Simple enough to get, quick, takes very little time, but CAT scans are radiation. So if you're getting a CAT scan, you're getting exposed to high doses of radiation. So as a surgeon, I have to sit there and go, is it worth getting the CAT scan to know how much calcium is there? 95% of the time, it's not worth it. It doesn't add enough value. The risk is too high for the reward. On the other hand, in a few patients, when I look at the MRI and I see what looks like really big clumps of calcium, we call that OPLL, ossification of the posterior longitudinal ligament, I will get a CT scan just to see how much calcium there really is. And if there's too much, we cannot do the laser surgery. If you have OPLL, segmental or continuous cervical OPLL with large calcium deposits, the laser surgery doesn't work. We need to do a posterior cervical laminectomy infusion.
These next three questions are from Izad on YouTube.
Hello, Izad, welcome.
First one, for cervical, the procedure is preferably done from front or rear?
The best treatment for a cervical disc herniation is through the front, not the rear. Never the rear.
Next question, if the procedure from front, won't it be dangerous being closer to the vein, or I think you meant jugular vein?
Yes, of course it's dangerous. All these surgeries we do are dangerous if you don't know what you're doing. I'm extremely well trained and one of the top spine surgeons in the world, so I know what I'm doing and I prepare properly for the surgery. Everything I do, I'm a minimalist, meaning I do the minimal that you need to do to get the best result possible. And so if you see me doing something, intubating the patient for general anesthesia, giving a muscle relaxer for relaxation, all of those things that I do are absolutely necessary, in my opinion, to get the best result. And that's why we do them.
And then lastly, from Izad, any difference between a disc bulge and a herniation?
Yeah, there's no difference between a disc bulge and a herniation. They're the same thing. A disc bulge is just a smaller herniation, but they all cause symptoms in patients that are suffering with them.
And that is it?
All right, next patient is a 3-level lumbar. She comes from Bermuda. She flew here for the surgery. Like many of our patients, she traveled from other countries, and we're going to be doing her surgery next. After her, we're going to do a Deuk plasma rhizotomy for facet pain, bilateral L344551, but you're not going to see that one because it's in our other operating room that doesn't have a camera system. And then we'll be back again for another surgery, but we've got a lot of surgery